let me help you understand lung mechanics on the ventilator on one piece of paper. To understand lung mechanics, I wanted to refresh your mind on what we said on our two main modes, which is assist control, volume control, and assist control, pressure control. Now, we always set the FiO2 PEEP and respiratory rate, right? What changes is tidal volume flow, inspiratory time, and inspiratory pressure. In ACVC, we're going to set the tidal volume and the flow, and in pressure control, we set the inspiratory time and the pressure. That's important to know because I want you to know what is the constant. Constant means you set this value. And what changes when there is a change in lung mechanics. So in volume control, the tidal volume and flow will always be constant. What will change is your pressure. And opposite, in pressure control, what's constant is your pressure, and what will change if your lung mechanics change is your tidal volume and flow. So that's your clue that something else is going on. Now, when I say lung mechanics, I am talking about compliance and resistance, okay? So our surrogate for our resistance will be our peak pressure, and our surrogate for our compliance will be our peak plateau. I wrote the equations here for you. I also wrote the normal ranges for resistance and compliance. Now, peak pressure is given to you. Plateau pressure, you have to check by doing an inspiratory hold. The inspiratory hold is so that the pressure can equilibrate between the airway and the alveoli because you really care about the pressure inside the alveoli. And so if you have a high peak and a normal plateau, that means that that is a primary resistance issue. So that means the patient is biting the tube, there's kinks in the circuit, there's secretion, maybe a mucus plug, there's bronchospasm, or the ET tube is too small, or there's a film on it or something that has decreased its diameter. I wrote the usual solution for each one of these things here. And then if there is an increase in both the peak and the plateau pressure, now we're thinking this is a compliance issue, okay? So the differential for that is a little bit longer, and obviously the treatment for that is a little bit more complicated. So it could be ARDS, pulmonary edema, pneumo, effusions, right main stem intubation. What I want you to really rule out in these circumstances is a pneumothorax, abdominal distension, meaning even like a ruptured viscus, okay? And then autopeep, because autopeep can act as an obstructive like shock if it is high enough. So those are the three main differentials I want you to rule out first before we can say it's pneumonia or it's edema.